Hi, this is Tom Shannon. In this presentation, we will be talking about the prostate biopsy. It's important to understand why we need to do a biopsy. Even though we have PSA tests and MRIs, it's really not until we see tissue under a microscope that we're able to determine whether or not that you have cancer. So if there is a suspicion for cancer, tissue must be obtained to make the diagnosis. The pathologist then looks at the tissue and gives us more than just a yes or no answer. He's able to give us information which is vital to the diagnosis and the treatment choices which you'll need to make. And this is based on grade and stage, which we'll follow in the next presentation. Based on these findings, we can then put you into a risk group that determines whether you're at low, moderate or high risk disease. Prostate biopsy is considered the definitive answer in determining whether cancer is present, and treatment will not be done until a biopsy is performed. So how is a biopsy done? There are two methods that we can use to biopsy the prostate gland. These are transrectal and transperineal. The prostate is very low in the male pelvis and is easily felt by inserting a finger or probe into the back passage or rectum. Traditionally, most biopsies have been done via a transrectal approach, as it affords a very good access to the peripheral zone of the gland, which is the side next to the rectum. Most cancers are in the peripheral zone and therefore very accessible by this technique. The biopsies are simple to perform and relatively quick and painless to be done. They are done under a short anesthetic so that you're asleep and unaware of the procedure being done. Transperineal biopsy is a different technique which involves again inserting an ultrasound probe in the rectum, but the needles are inserted differently through the guidance of a template that is placed above the skin between the scrotum and the back passage. This has some advantages and disadvantages. The first advantage is that the needle does not pass through the rectal wall, which in theory should reduce the risk of infection. The second is that given the template is a rigid structure, we are able to direct the biopsies to a specific point in the prostate gland. The problems, however, are that the needle does move once it enters the prostate, and it's not necessarily as accurate as you may expect. The separations on the template are 5 millimeters apart, and given that some lesions that we want to biopsy are smaller than this, it's possible that these lines do not line up exactly with where we want to biopsy. Given that the prostate does move and it may be difficult to access a particular spot, then biopsy through the template may not hit the region that we feel that we are trying to hit. The posterior portion of the prostate can also move away from the biopsy needles, again making this technique better for lesions that are in the front or anterior portion of the prostate gland. I tend to use transperineal biopsies when I have an identifiable lesion in the front portion of the prostate gland on MRI, which may be more difficult to reach accurately with a transrectal approach. More recently, we have been adding in an MRI-directed biopsy, where biopsies can be done directly in the magnet. This tends to be appropriate for lesions that are relatively small and difficult to access, but there is no need to consider MRI-directed biopsy for every case. The risks and complications of prostate biopsy are fairly low. It's not considered to be a high-risk procedure. All the biopsies are done under a short anesthetic so that you are unaware that the procedure is being carried out. MRI-directed biopsies are done under a local anesthetic. Given that with an MR biopsy we're usually only taking 1 to 2 cores, this is less of an issue. It's known that you will see some bleeding with a prostate biopsy, as we will be entering the prostate gland. Blood can be seen in the urine, it can be seen in the back passage, and it can also be seen in the semen. The first two tend to clear fairly quickly. However, blood that remains within the prostate is cleared slowly with ejaculations, and it can take up to 10 ejaculations before the blood clears completely. Most patients do not have significant pain after biopsy, but there is discomfort which is easily controlled with simple painkillers. If you're already having difficulty passing urine, then you can have increasing troubles after a biopsy. This seems to be a bigger issue with the transperineal approach, especially if extra biopsies are taken. Erection problems have been reported after biopsy, as the erection nerves do run very close to the prostate gland. It's important that when the biopsies are taken, that the direction of the cause is away from these nerves. In my clinical experience, I have not seen men complain of erection problems after a prostate biopsy. The main issue that we have with biopsy is that of infection. Infection can occur with significant bacteria that require you to attend hospital for intravenous antibiotics. In our series, the infection risk is less than 1 in 500. So what is the preparation for a biopsy? Well, to reduce the risk of infection, we generally clean the bowels out with an enema. We use a suppository with betadine, which sterilizes the lower end of the bowel, and we give tablet antibiotics both before and after the procedure. Biopsies are very important in WA because compared to other reported series, we find a lot more cancer. In fact, it's 1.6 times than was seen in the American screening study and twice the rate of that seen in the European. You can see on this pie chart that around 60% of our patients do have cancer, with 25% having abnormal results on top of this. Most of the cancers we detect in Perth are significant, both by volume and by grade. The largest group are the Gleason 6 and 7s, and these vary in their significance. Roughly 20% are very high grade, and unfortunately many of these are advanced at diagnosis.